Uh, Professor Kushner, can you hear me, please?
I can hear you well. Can you hear me?
Yes, sir, we can.
Okay, good.
It's me here. I'm Amitabha. I'm the current president of the SPOSI here, sir. And
Good.
yeah, and we'd like to wish you a very happy good evening there. And I'll pass on the mic to Professor Pandey on my left, who's the secretary of the association, who will introduce you to the audience, please.
Thank you.
Thank you, sir, for giving us this opportunity and being with us on this for this very important topic of intermittent exotropia. Professor Burton Kushner graduated from Northwestern University School of Medicine in 1969. He subsequently did his residency in ophthalmology at the University of Wisconsin, Madison, followed by a fellowship in pediatric ophthalmology at the Bascom Palmer Eye Institute. Afterwards, he returned to Madison, where he became the John W. and Helen Doolittle Professor of Ophthalmology and was director of the Pediatric Eye and Adult Strabismus Clinic. Dr. Kushner is currently Professor Emeritus in the Department of Ophthalmology and Visual Sciences at the University of Wisconsin, Madison. He has been the secretary for the program of the AAPOS, editor-in-chief of the Journal of Pediatric Ophthalmology, founding editor of the Journal of AAPOS, and co-editor-in-chief of the journal Binocular Vision and Ocular Motility. He has published over 200 peer-reviewed manuscripts, authored 41 textbook chapters, edited 3 textbooks, and was sole author of another 2 textbooks. Dr. Kushner has given over 25 named lectures, including the Scobie Lecture, the Kostenberger Lecture, and the Belshowski Lecture. The many awards he received include the Heed Award, the Bressler Prize, and the Senior Honor Award from both the AO and the AAPOS. He has been listed in every annual edition of the Best Physicians in America since his first publication in 1993 and was listed in 20 most innovative pediatric surgeons alive by top masters in healthcare and administration. The vast majority of these publications have dealt with strabismus and disorders of binocular vision, including improvement of visual fields after strabismus surgery, a hypothesis on the mechanism of overacting muscles, mechanisms of ocular torsion, and a body of work on intermittent exotropia. Sir has very wide-ranging experience on intermittent exotropia, and as we all know, it is a very common disorder, and the incidence is rising in our part of the world, in especially Asia and South Asia. That's because probably myopia is also rising, and more sunlight, and ethnic issues. So it's a very difficult condition, enigmatic condition, difficult to treat, and a lot of controversy surrounding this particular topic. So sir is going to address some of these issues in his oration on intermittent exotropia. Sir.
Thank you. Thank you for that lovely and very generous introduction. Let me start by sharing my screen, which will take me just a second. And you should be able to see that. Let me, except I'm not able to get it into the production, the mode to show the slides. Bear with me a minute. Something is not working right on my machine. I'm gonna start that over again. Let me just resume the sharing the screen, and we'll do that. Now, okay, let me start it this way. Presenter view. Well, there we are. Can you can see my screen?
Yes, sir. Yes, sir.
Yes. Okay. So, I'm seeing some different interfaces that I haven't seen before. Bear with me a minute. Access the microphone. Okay, so thank you for bearing with me. I'm going to talk about what I've learned in 45 years of studying intermittent exotropia. Subject been very interesting to me. And I'll start just by briefly giving what I'll call the history of this journey. It actually started when I was a first-year resident in 1970. And I learned Burion's famous classification of intermittent exotropia, which actually dated back more than 20 years prior to that, from the 1950s. And as we know, he categorized them as divergence excess, basic, convergence insufficiency, and pseudo-divergence excess. And the treatment was determined based on the classification. And after a short period of time, this just became concretized. It became set in stone and has lasted for the subsequent 50 years. But when I looked at it, as a first-year resident, actually, I thought that there were some internal incongruities and inconsistencies in his reasoning. And I'm always amused when I think of this to show this slide. This was my daughter's vehicle when she started driving, and that was her bumper sticker, question assumptions. And that's something that I have tried to do throughout my professional life. Now, with intermittent exotropia, and we're going to go through a whole bunch of topics related to intermittent exotropia, I want to start with the presentation. When a patient comes in, there are two equally important things that you need to determine. One is the patient's control, how well they keep the deviation from being manifest. And the other and separate is the angle, the size of the deviation. Now, the control tells if a patient should be treated. Good control, you may not need to do anything, even if the deviation is very large. Poor control, you may need to do something, even if the deviation is small. The angle tells you how much to do once the decision is made that you have to do something. So in order to assess control, because that's what drives how you're going to manage this patient, you should develop a control score, a scale. And there are several that are published. I think it's not so important which one you use, as it is important that you have one that is internally consistent for you. That when you list a patient as having, let's say, fair control today, it means the same thing as when you saw that patient a month or two earlier and labeled them as having fair control. Now, I personally like a control scale that has two phases. I give one score for how easily the patient breaks. Do they drift out spontaneously? Is it only after a cover? And so on. And a separate score for how quickly they recover. Once they're broken, they're tropic. Do they bring the eye back quickly or not? All the published control scores conflate the two. They'll assume that if there's good control as far as not breaking easily, there's quick recovery, and they don't always go hand in hand. So and the exact scale I use isn't that important as much as you develop one that you use, that you're comfortable with, and that it's consistent from one exam to the next. Now, when a patient presents with intermittent exotropia and they're very young, and I arbitrarily say about 3 years of age, I like to drag my feet, even if their control is poor, if I can keep them fusing. Studies have shown, multiple studies have shown, that there's a high incidence of postoperative monofixation syndrome when patients are operated on at a very young age. And it's actually not clear why this is. It might be because the initial overcorrection that we all desire in a very young child, maybe even a week or 2 or 3 of being esotropic, may cause them to lose bifoveal fusion, and they will forever be monofixators at best. But the other possibility is that this relative adverse outcome is due to pre-existing selection bias. Perhaps the patients that present at a very young age with very poor control are patients that don't have as good a fusional mechanism to start with. It's a hard question to answer, and I err on the side of caution, and I'll be conservative with these patients. I will temporize if I can. And if I can't, as long as if I can't temporize, if I feel I have to operate on them, I will definitely avoid leaving them esotropic for a prolonged period in the postoperative period. A week or so in a very young child is the most I'll accept. And if they're still esotropic, because I think it's important to have an initial overcorrection, I may patch them, I may use Prism. That's a typo. I wouldn't use over minus in that setting. Phospholine iodide is what I'd be using for a patient that's an overcorrected exo and they're now ESO. But the important thing is not to leave the very young child esotropic very long. Now, a very important principle in all patients that have unstable fusion mechanisms or intermittent strabismus is to correct anisotropia. And to use the term I use is to balance the refraction. If you don't give them the cycloplegic refraction, you have to cut the plus or increase the minus in equal amount in both eyes, because accommodation is equal and symmetric. And I have a couple case examples that'll demonstrate the importance of this. So I saw this 25-year-old patient, a woman, and she comes to see me after 3 prior surgical procedures for intermittent exotropia. And even though intermittent exotropia recurs a lot, often, 3 is a lot of surgical procedures for that condition. She comes to see me. She had been advised to have a 4th surgical procedure. And when I examine her, I see that she's plano in her right eye and minus 350 in her left eye. And she tells me that she was told she would never need glasses because she uses one eye for distance and the other for near. And in fact, she does independently. And with that much uncorrected anisotropia, she has, in my opinion, very little chance to establish binocularity. All I did for this lady was put her in proper glasses. And after 6 months of wearing, she had a well-controlled deviation, and she continued to control it for a number of years that I followed her thereafter. I was tipped off to this importance of this by Art Jampolsky. He wrote a very scholarly chapter in the Transactions of the New Orleans Academy about unequal vision inputs as being destabilizing in patients with strabismus. Here's another example. Unequal vision inputs are destabilizing. A young boy comes to see me with a left intermittent exotropia of 25, and it's poorly controlled. And this is his cycloplegic refraction. His fixing eye, just a little bit of spherical hyperopia. His left eye, he's got myopic astigmatism. I ordered glasses for him, and just because he's exo, I cut the plus by half a diopter in both eyes, or increased the minus in the left eye by half a diopter. And it turns out that the opticians who dispensed the glasses made a mistake and reversed the prescription. And they gave him the -3 with the 1 cylinder over his almost ametropic eye and gave him plain over his other eye. Now, when you realize that minus lens will help an exo control their deviation, the question I asked myself when I heard this happen is, would he be better in these classes or would he be worse? Now we're having him accommodate 3.5 diopters in his fixing eye. But in fact, he comes back, his control is worse and the angle is worse. All I did is correct the error the optician made. I had the proper glasses ordered and he dropped down to a well-controlled 10 prism diopter exophoria, which was stable for the 8 years that I followed him. One last example, in case you need more convincing of why monovision can be detrimental to patients with strabismus. Now, this is a video of a patient with an intermittent exotropia of the right eye. Here he is straight, and when we cover the non-dominant eye, it goes out, and he corrects it by making a vergence. When we cover his fixing left eye and uncover it, he refixates with the left eye and then brings the right eye in. With minus lenses, and here I'm holding up -2, that completely corrects his deviation. Minus lens will help. But if I put the minus lens over just his fixing left eye, he can't control the deviation anymore. So again, the importance of equal vision inputs, the harm of unequal vision inputs, and the harm of monovision in patients with intermittent exotropia. Okay, when do we intervene? Well, in general, the principles that I have is if the intermittent exotropia is manifest, they're tropic more than 50% of the time. If my control score documents that the control is definitely deteriorating from one visit to the next, or if there are symptoms of diplopia or asthenopia, that's my indication to intervene. Now, in most patients, at least children who come to me, I first intervene with non-surgical measures, with sort of orthoptic medical management. I begin with alternate occlusion, and that's not for amblyopia treatment, it's for anti-suppression. And I'll typically patch 3 or 4 hours a day, and their fixation pattern will determine the exact pattern. If they're free alternators, which is relatively uncommon in my experience with intermittent exotropia, I'll do one eye one day, the other eye the next, and so on, back and forth. If there's a fixation preference, which most of them have, I'll patch either 2 days over the dominant eye and 1 over the non-dominant eye, or 3 in 1 if it's a stronger fixation preference. Of course, if they're amblyopic, I only patch the dominant eye. Now, what's interesting is that this program, this anti-suppression program, I'll see the patients back in a month, and almost invariably, their angle improves as well as their control. I can understand why their control improves. I don't really understand why their angle improves, but it almost always does. And then I'll slowly wean them off. I'll decrease the patching, cut it in half again, and over a period of months, I'll wean them off patching. Now, in a small number of patients, this will be curative, but in others, it does often recur. If it recurs, I'll repeat this program. I will start occlusion again, but then, and almost invariably, they improve their angle and control. But this time, before I start tapering the patching, I'll over-minus them and use some prism. Now, I know there is a recent study that said over-minusing causes an increase in myopia in these patients. That study used what Jampolsky originally recommended, which was 3 diopters of over-minus. I typically over-minus by less. I over-minus by 2. And then if I put 2 or 3 prism diopters base in each lens, total of 5 or 6 prism diopters of basin prism, that will give me the equivalent of that third diopter of over minus. You think of the ACA ratio, 6 diopters, prism diopters would be equal to about 1 diopter of accommodation. And I wean them out of this always by the end of their teenage years. Now, this allows me to bide time. In a young patient, I can wait and operate when they're older. And in even the somewhat older child, it allows me to see them more often, get better measurements, and just bide time, which I think works in their benefit. Often it'll give me several years, and again, in a small but a very definite number percentage of these patients, it can be curative. If surgery is indicated, let's say the alternate occlusion didn't work, or if we tapered it off that second time, the patient is again controlling poorly. In my practice, all patients with intermittent exotropia get a 1-hour patch test to determine the maximum angle, not just for near, not just to uncover the simulated divergence excess, but many will increase their distance angle after an hour of occlusion. I also have them fixate an outdoor target, a far outdoor target, a couple hundred yards away or more. And many of these patients will increase their angle of deviation either in the distance, in the exam room after the patch, or while looking outdoors. I do both tests, and I operate for the largest angle, the largest deviation that I find. It's interesting to me. I've looked at this in a very prospective, rigorous manner. Some patients will increase with the patch, others will increase with the outdoor measurement. They're not necessarily the same patients. I think you need to do both and get that maximum angle. Now, just a word, if you obviously, and in India, it's certainly not as cold as Wisconsin in the winter. You can take patients outdoors. But if you take them to a window, this slide shows that the distance that the patient is from the window is important. This is just a hypothetical drawing, but here's a patient X distance from the window, and the outdoor illumination coming in from the window subtends, in this case, 70 degrees of retina. If you just double the distance, keeping the window the same size, you're only having that window falling on 30 degrees of retina. So you want to have the patient standing as close to the window as you can, still giving room for you to get in front of them and do a cover test. You want to have that distance the minimum that you can. Now, just a word about this business of what I call outdoor sensitivity. That's the patient that when they look at a far outdoor target, they increase the angle of deviation as compared to what you see at the typical 6 meters. And I wanted to look into whether it's the increased distance or the increased light that causes the larger deviation. And it turns out it's both. I had 76 patients that I studied that all had this outdoor sensitivity, and I measured them both indoors in a long corridor, 24 meters long, and I also measured them at 6 meters with floodlights simulating outdoor illumination. And just to summarize what's at the bottom of the slide, some increased with the longer distance with normal illumination, some increased with the light at 6 meters, some would increase their deviation with either test, and some needed both. They had to be measured basically on an outdoor target. So this is where intermittent exotropia, I think, got a little confused and complicated. I want to talk about what I used to call tenacious proximal fusion. I now call it the SPOSI phenomenon because Richard Scobie was the one who really discovered this. So here's a very typical patient, these 30 prism diopters exo at distance and they're ortho at near. It's a very common presentation. This is hypothetical. If you patch the patient for an hour, many of these patients, this is Scobie's observation, will increase that near angle to be about the same as the distance angle. And the way I look at that, this foretells a better prognosis. The presence of this phenomenon, tenacious proximal fusion, now called the Scobie phenomenon, speaks for a stronger fusional mechanism and a better prognosis. So let's talk about distance near differences as Burton categorized them. What he called a divergence excess, in my mind, and I don't have time in this lecture to go into details as to why, but it's in some of my publications, it's probably not an excess of divergence. It's probably a patient with an exotropia that has some kind of excess of near convergence. Maybe accommodative, it may be something else that decreases the deviation in the distance. The basic, lack of a better term, I think we can keep that term. And the convergence insufficiency, bigger deviation at near, I'm going to talk about that on another slide in more detail. Now, the pseudo or simulated divergence excess, both terms are used, are the patients that have the Scobie phenomenon. If you patch them for an hour, the deviation will increase. The literature got confused in the 1950s where many people said, well, +3 lenses at near will do the same thing. And if you think about it, patching and +3 lenses are not the same. One suspends accommodative convergence and one suspends fusional convergence. Yet both may diagnose the pseudo-divergence excess patient. And why both, even though they work on different mechanisms, is not necessarily immediately understandable or graspable. And I'm going to try and hone in on that. This is the important point with assessing distance near differences with intermittent exotropia. ACA ratios in intermittent exotropia can be calculated in all the usual ways: gradient method, heterophoria method, distance near for the gradient, provided, very important, that any near measurement that goes into the calculation is made after you've eliminated the, I'll say, contaminating effects of tenacious proximal fusion, the Scobie phenomenon, with a 1-hour patch test. So let's see why plus lenses may do the same thing as a patch. Here's our patient, 30 distance, ortho at near. Now, if you just hold up +3 lenses at near in this hypothetical patient, the deviation at near increases. It's 30. You could say, is this a high ACA ratio? Well, if you just do a calculation of a gradient ACA, 3 diopters of relaxing of accommodation gives you 30 prism diopters of deviation. That's an ACA ratio of 10. So seems high, but it's probably not, because in most of these patients, you didn't eliminate the Scobie phenomenon with a patch test first. So if we take the same patient, hypothetical, but very representative of most of these patients, 30 and ortho, if you patched them first, you'd see they're the full 30 at near. Then if you introduce the +3 lenses, they're going to only increase, let's say, another 10. That's an ACA ratio of a little over 3, a normal ACA ratio, actually bordering on low. So you have to realize the two tests are not interchangeable, and there's a role for doing both. This patient, this hypothetical patient, has what I call a pseudo high ACA ratio. Now, you want to beware of the true high ACA ratio patient, and they're very rare in intermittent exotropia, but you need to recognize them because if you don't, you'll have an adverse outcome. These patients, they start with the distance greater than near. They do not increase it near with a patch test, but they do increase it near with +3 lenses after the patch test is done, after you've suspended tenacious proximal fusion were it there. If you do a gradient ACA, it's high. And a very interesting pearl is if you measure them very close up, like 3 inches perhaps, they actually have an esophoria in there. Where most intermittent exos, you will be exceeding their near point of convergence and they break and they'll have an exo. Now, it's important to recognize them because these are the patients that will have an esotropia at near if you correct the distance with surgery. And I found that patients that meet this criteria, there was 100% sensitivity and 100% specificity for having an esotropia at near if surgery left them ortho in the distance. On the other hand, because they have a high ACA ratio, they respond very well to over minus lens, but because they're esotropic at near, they need a bifocal. Their ACA tends to normalize by the end of their teenage years, and then you can treat them surgically like any other intermittent exotropia. I found that what I call a rapid prism adaptation test was qualitatively, but not quantitatively the same as the patch test. So what I would do, patients 30 distance ortho near, I just put 30 base in the office in a trial frame, and I just have them read a paragraph and do a quick cover test, and in a matter of half a minute, their near deviation increases. But whether a classic prism adaptation would bring out more of these patients is something that has not rigorously been studied yet. And I think that's worthy of a prospective study, which actually is being planned right now. So surgical recommendations. Burion's recommendations were based, in my mind, on the false assumption that lateral recessions affects the distance greater than the near, and R&Rs affect the distance and near equally. And I think Steve Archer and others have shown that this is actually probably not the case. My thoughts are that the divergence excess patients, true divergence, is probably masking a larger near deviation. And I've found from my own prospective studies, lateral recessions or R&Rs, your preference, works as well in this patient. The basic patient is the patient that doesn't have the SPOSI phenomenon. So they have a poor prognosis, a poor fusional mechanism. And you need to do something more in these patients. Now, R&Rs, which kind of tether the eye from going out, work better than standard lateral recessions, but studies have shown that lateral recessions with an increased formula, if you add 1.5 millimeters or 2 to your recession, you will get as good results as you will with R&Rs. The pseudo divergence excess, that's the SPOSI phenomenon present. I think you can do lateral recessions or resect, your preference. Now, a word about convergence and sufficiency. And I think it's kind of unfortunate that we use this term to describe 2 different types of patients. There's the patient with the fusional convergence and sufficiency. That's a patient with a trivial distance phoria. They're typically not tropic. They have a bigger phoria at near. They have low convergence amplitudes, and they do well with convergence exercises. But the patients that are the really difficult ones, if you really check them, ACA ratio calculations in the ways I've described, you'll find that they have an accommodative convergence insufficiency. Normal accommodation, but very low ACA ratio, no accommodative convergence. So they have a small tropia at distance, intermittent tropia, a larger one at near, often 15, 18 prism diopters more, very low ACA ratio. And that's why I think no surgical option, there's no surgery that will really increase the ACA ratio. I think you can get equal results with medial resections or recess-resect, but basically you're not going to completely collapse the distance near difference. If you straighten them at distance, you'll have a residual deviation at near. If you straighten them at near, you're going to overcorrect them at distance. I, in recent years, have added what I call the Buckley procedure. This is something that Ed Buckley described, where he will intentionally transpose the medials up or the laterals down to induce a V pattern where there wasn't one there before. And I find about a 3/4 tendon width transposition will give me about 8 prism diopters of V, and that will help decrease. So you operate for the distance, you have a residual ESO at near, exo at near, and in the down gaze position, giving a V pattern helps collapse that V, collapse the exo. A word about lateral concomitants. This was described by Phil Knapp and Sally Moore, that there's a small, they've thought a lot, I think it's a small subset of patients, intermittent exo, where the deviation decreases in right and left gaze. And it's been described as either decreasing by 50% or 10 prism diopters. The important thing is it goes down in both right and left gaze, and they found there's a very high incidence of overcorrection if you operate on these patients in the usual manner. Now, if you think about this mechanistically, there are very few things that could cause this. What would cause a deviation and decrease in right and left gaze? Well, one would be if the lateral rectus muscles are weak. It's kind of hard to fathom, though, that an intermittent exo would have weak lateral rectus muscles. The other is if they have overly strong, not tight, but overly strong, contractile medial rectus muscles. That must be the case. And that would explain why these patients are prone to overcorrection. If you weaken the laterals and now the medials are overly strong and they're opposed by weakened laterals, patient goes esotropic in primary. So how prevalent this entity is isn't clear. Some people feel it's an artifact of measurement. I don't think it's as prevalent as Knapp described, but I think it's it definitely exists. But what no one has ever talked about, to my mind, is what if you see this pattern after a patient's had prior surgery? We see this patient had lateral rectus recessions and now the deviation recurs. And here's the same thing, 30 in primary, 15 in right and left gaze. This patient, unlike the patient that has this de novo, has iatrogenically weakened muscles. So there's a different mechanism going on. And these patients are not overly prone to overcorrection in the primary position, but they may be overcorrected in side gazes, and you have to tailor your surgery accordingly. So I'm very near the end. I just want to wrap up with talking about my surgical endpoint. I aim for an immediate overcorrection of 5 to 15 prism diopters in intermittent exos. Somewhere in the early 80s, Marshall Parks wrote he likes them 10 to 20 prism diopters ET on day one. In my experience, the patients that are over 15, that's too much. They don't straighten. But what isn't talked about in the literature is the fact that adults, at least in my experience, don't straighten the same way as kids do. And I do not aim to overcorrect adults. I aim for ortho. I do lateral recessions typically with adjustable sutures. I like them ortho and primary, just bordering on diplopia in right and left gaze. So to summarize, we've talked about when to operate. You don't want to operate on the very young patient. I went over my protocol for conservative management. All patients have an after patch and far distant outdoor measurement. Talked about distance near differences and the importance of the Scoville phenomenon and the effect on surgical planning, the difference between the fusional convergence insufficiency and the accommodative convergence insufficiency, talked about the true high ACA ratio, and aiming to overcorrect 5 to 15 prism diopters. With that, I want to thank you. I realize I went a little over time. I attribute that to the fumbling I had to do with the PowerPoint at the beginning. I hope you'll indulge me that. And I'm going to stop sharing and see what happens next. My screen went blank. Hopefully it'll come back. There we are. Okay, thank you.
Thank you, sir, for a very comprehensive talk. I think there will be certain questions. I think screen off. Okay, can you put it back? Sir, audio. Sir, can you hear me?
Yes, I can hear you.
So this is a very interesting and very challenging topic, and I'm sure there will be certain questions. I will just take 10-15 minutes more, sir, so that some of these issues people can. You want to ask something, Dr. Maya?
Yes. Thank you, sir, for such an enlightening lecture. Sir, I have 3 questions in my mind. So I would actually tell all of you, ask all of these from you. So first is that how do you titrate the over minus lenses for intermittent XT? Because what we have observed that whenever we are trying to over minus more than 0.75 or 1, the visual acuity tends to come down. So in those cases, how do you titrate? Do you take that one line visual acuity decrease is okay for a better control if we are targeting a 2 over correction? This is my first question.
Let me answer them one at a time. So if that's okay. So I didn't specify age. I'm usually doing this in younger patients. It would be very uncommon for me to be starting with over minus lens in 7 or 8 year old even. This is something I'm more apt to be doing in a 3-year-old, 4-year-old. I have not, I can just say my experience. I cannot remember a single patient that complained about decreased vision. The younger child, I don't know if there's a cultural, ethnic difference. The younger child here, they can accommodate and they overcome that. I had a colleague who used to over minus 4 and 5 diopters, and that was horrible. Patients did not accept that. I saw many of those patients who were quite unhappy. But 2 diopters, I've just not had a problem accepting it. If I experienced that, if I had a patient who was blurred, I obviously wouldn't do it. I would then have to do some kind of a formal titration and see how much minus they could take. I just don't think I've ever had to do that.
Do you use over minus therapy only for high AC by ratio patients, or you are using them in all types of IXT?
In the high ACA ratio, which is a very, I think when I published my article, which was a while ago, I think I only had like 8 patients ever that I saw that has the true high ACA, if tested the way that I have. Those are patients that you can actually get straight. You get a lot of correction for a small amount of minus. But I use the over minus as a follow-up in all patients that accept it, parents that accept the treatment, and so on. If the initial intervention with patching, if it recurs. So that would be regardless of whether they're high ACA or not. So if you think about a normal ACA, and I'm incorporating a total of about 5 or 6 of prism in the glasses also, that should decrease the deviation to over minus 2 and the prism should decrease it by about 15, which should get most of these patients. That's enough of a decrease that they can comfortably fuse. So it's not just the high ACA.
So it can have broader implication. Other patients can also be treated with over minus therapy.
You can, yes.
Other things are in small children below 3 years. You said we should wait, but there are some children who are breaking down very frequently, and they have a large exo. I think there one has to intervene. There is no way out. And other thing is about the surgical dosages in children versus say adults. I've seen children who are younger. I mean, about till 7 years also, the response is much more as compared to adults. So, do we make any difference there? We take less dosages for younger children. Do we?
Any difference? Do we get? I didn't hear the last. Get less what?
Surgical dosages are the amount of surgery we do for the same amount of deviation in younger children and older patients. Do we do less surgery for children for the same amount of deviation?
The formula that I used, I did not make a different allowance for adults and children. If I say in adults, I may target a different angle. Is my video? Oh, excuse me. Somehow that got shut off. There I am. My video should be back. I don't know why it got shut off. No.
Okay, we thought you shut it off, sir. It is some technical.
Yeah, I know, but it says here that it's on.
I was told that you have shut it off, sir.
Yeah, it says that, but I do not.
You're not able to connect. Can you help?
Let me just see if I can get that to come on.
Please.
No, it says my video's on. There's no line through it. Stop. Start. I'm gonna start video. I'll try it again. I'm sorry. You can hear me at least, but
yes, sir. So another very important question is about bilateral lateral rectus recessions versus resection and recession. Yeah. Now, is there any indications, strict indication for doing recession and resection, or almost all cases can be treated by bilateral lateral rectus recession? I think we are moving more towards bilateral lateral rectus recession.
Yeah.
Rather resection. Sir.
I think you can treat them all with lateral recessions. That was my bias in an amblyopic, a patient with amblyopia. This is disturbing me about my video. Everything here on my screen says my video is on.
Yes, sir.
And it's not coming on. Let me FaceTime. I don't know what else. I've done enough Zoom sessions. I know when the line's through the icon, the red line, it means the video is off. I don't know. I can't. If you have any suggestions, I'm happy to put it on, but you can hear me.
Sir, our technical team is working on that. Meanwhile, we can continue the discussion, sir.
Yes, you had some more questions.
Yes, sir. So my second question would be that as you said that in intermittent XT, it is better to over minus. But what happens if in intermittent XT, we are getting a hypermetropia, and that too in a small child, in a child who's less than 4 years, not able to tell that which visual acuity he's getting better with a small correction or not. And that too, when we get a different hypermetropia, a small hypermetropia that is somewhere around in less than 4 years, we are getting somewhere around 2 or 3 hypermetropia, or a very large hypermetropia in the range of 7 and 8. So how should we deal with that?
Okay. I'm glad you brought that up. And if I had an hour for the talk, I would have gone into that. And I included this in at least one of my manuscripts. I probably was somewhat inconsistent. I mean, I practice, I see patients and I treat them the way I think each individual patient should be treated. If they're myopic or plano, I would over minus them by 2 diopters. That's straightforward. So the question then is, what do they do? Let's say if patients 2 diopter hyperope, over minusing them by 2 is putting them in plano or cutting their plus. That's obviously not going to do anything. But if they're already accommodating 2 diopters without glasses, they're probably not going to comfortably accommodate 4 or 5 if I were to over minus them that much. So I would individualize it. I typically in my hyperopes, I would be, let's say a 2 diopter hyperope or more. I'd probably I wouldn't put them in more than -1, which is in a way over minusing them more than 2. But and as I say, if I looked at all my patients, I was probably inconsistent. Now, there's another patient type, that's the intermittent exo with high hyperopia. And this was described, the group from Ann Arbor, Michigan, and actually the lead author was an orthoptist, Aida Ayakabuchi. These are patients that are 7 or 8 diopters hyperopic. And what they did in their study is they would give them full plus. The idea being, they're not manipulating accommodation. These patients were so hyperopic, they just were blurred. They were, before the glasses, they weren't accommodating. And blurred vision destabilizes unsteady strabismus. So intermittent strabismus. So they would give them full plus, and they would find many of them actually straightened completely with that. Now, my own the approach I've always taken with everything is, if there's good data for something, then I follow it. And if there isn't good data, I do what makes sense. And it makes sense to me to cut the plus a little bit, half a diopter, 3/4 of a diopter, just to you're going to eliminate the blur. They probably have weak accommodation because they've been not accommodating before, you put them in the glasses. But if accommodation does help stimulate emmetropization, it makes them closer to what a normal child their age would be doing with respect to accommodation. So that's what I do with the high hyperope. So I've talked, I think I've answered what I do with the low to moderate hyperope and the high hyperope. And I always correct astigmatism. I mean, a 1/4 diopter, maybe not, but any significant astigmatism, fully correct, never alter the axis. I don't know why some people will change the axis. Astigmatism, in my mind, should be corrected on axis. And I'm going to try one more time to get my video going. This is really bothering me. It says my built-in FaceTime camera is on. And
What about vertical deviations, sir? How often you encounter vertical deviations with the intermittent exotropia?
Yeah, I think vertical deviations, I think that I would have to answer that in 2 parts. I'll say significant or trivial. There's the intermittent exotrope that they have a 10 prism diopter hyper, and that's significant. I think that many of them will have small 2, 1, 2, 3 prism diopters. And if it's that small, I may ignore it with my surgical treatment. Or let's say if it's getting up around 4, I may treat it just with, and it's not a pattern. It's not due to an overacting oblique or a paretic superior oblique or something like that. I may just do small offsets of the muscles, raise one, lower the other, to get a little bit of correction. So I think that the significant vertical, where you really think, oh, should I do a 3rd muscle? They occur, and it's in my practice, it's a pretty small subset of patients. And if I look very carefully for tiny verticals, it's more common. Did you
Thank
have
you, sir.
did you have another question yet? I think
yes, sir.
I
So
lost
just
count.
it's a
Yeah.
small one. For the lateral incompetence, you said that how much difference should we take as a lateral incompetence? Sometimes you find 5 or 7 diopter incompetence is there. And should we take it into consideration? And if present, suppose if we are taking 10 or 15 as a difference to be the definition of a lateral incompetence, then how much should we undercorrect?
Yeah. The way I I practiced was to call a patient as having lateral incompetence if it was 10 prism diopters or more of a decrease, 10 prism diopters or more of a decrease in both right and left gaze. Some of the early art, there were not a lot of articles about lateral incompetence, and as I recall, and I haven't looked back at this, someone talked about a percent, that if it decreases by a certain percent in right and left gaze, but that's not the original description. The original description was 10, and I never had enough of those patients that I could make any meaningful series of my own. So, I don't, the problem with the paper that Phil Knapp and Sally Moore wrote was they made this observation. They went back and they looked and they said, the orthoptist in the team realized, patients have this, we're overcorrected, but they never did a prospective. They never went forward and said, well, now we treated them by altering our formula by such and such an amount, and we got better results. They just said they're prone to overcorrect them and cut back on your surgery. And I never had enough of these patients that I could generate a meaningful series of my own. So I tended, I think if I would think back, and I was usually doing lateral rectus recessions on larger deviations, I'd probably cut back a couple millimeters on both muscles. And if it was a smaller deviation, by larger, let's say more than 35, smaller, 30 or less, I probably cut back about a millimeter.
Thank you, sir. I had one small question regarding the effect of occlusion in patients of XT. We see both the effects. We do occlusion to elicit the maximum amount of deviation. We do occlusion for short duration. And at the same time, we do occlusion for long duration to have the anti-suppression effect and enhance the control. And both these observations are there. Have you tried to assess the amount of duration that is necessary to have a significant anti-suppression effect?
Yeah, just as an aside, I just want to say, excuse me, I got a message on my screen that the host asked me to start my video, and I clicked a button saying start my video, and it still didn't come on. So I cannot explain what the problem is. You raise a very interesting question, and I thought about this, that there's some threshold between how much patching will bring out the maximum deviation, but if you patch longer, you're starting to decrease the deviation because of anti-suppression. And that hasn't been rigorously studied. There was one study, trying to think who did it. I think it was Bill Scott in Iowa, that they compared 1 hour of patching for intermittent exotropia to 24 hours of patching to see if 24 would bring out a bigger deviation. And as their conclusion was, there was no difference between the two. Now, it's very easy to be, if you're not the one who did the study, to look at it and then see flaws with the study and say, I would have done it differently. They talked about the mean change, average change, with 24 hours and with 1 hour. And what I personally would have, and there was no difference. I personally would have been more interested in knowing, just in raw numbers, how many patients had a different measurement, because the mean, if some measured more with the longer patching and some measured less because we were getting into anti-suppression, you could have had the means cancel each other out and there'd be no difference in the means, yet there might have been a number of patients that were different. My own feeling, and I don't have data or a study to back this up, is that anti-suppression effect doesn't occur in the very short term. It probably doesn't. I would bet even a week would not have much of an anti-suppression effect. Of course, it would depend if you're patching 24, all waking hours versus 3 or 4 hours a day. But the actual threshold between has not been studied. Does that answer the question?
Yes, it does answer the question, and it opens up questions regarding further studies to study the effect of the duration of occlusion and how much would be how much should be take as to have a meaningful anti-suppression effect. We would probably have to conduct some more studies to study that.
Yeah, I think that in my mind, all of the best questions are the ones that lead to other questions.
Anybody would like to ask anybody else? Dr. Sumita, please.
Good evening, Dr. Kushner. I would like to ask if there was really a true high ACY ratio and patient, would you plan a simultaneous surgery on medial rectus?
Good question.
Or would you do it on in a staged manner?
Yeah. So when I recognized the criteria for diagnosing the high ACA, and I retrospectively looked back and I saw it was 100% sensitivity and specificity for determining overcorrection. I basically said, I'm not going to operate on these patients until they outgrow their high ACA. There was a study done, Mike Brodsky did it, where he used the same criteria that I use for diagnosing a high ACA. And he did lateral recessions for the distance deviation and posterior fixation on the medials without recession. And he reported good results. Now, I never did that on my patients. I personally, and this could be a whole other talk, and we don't have time for it. I'm not. There are a lot of reasons I don't like posterior fixation for convergence XS. So I found that since these patients, ever since I recognized the entity, every single one that I saw, which is not a lot because they're rare, I was able to get to fuse with a small amount of over minus and prism. So I have not operated on them until they reach an age where their ACA became normal. And everyone that I followed by age 16, 17, one of them, I think 18, outgrew the high ACA. And then I just operated lateral recessions on them like any other intermittent exo, and they did fine.
Thank you.
Thank you.
What about Dr. Wright's formula of using an average of near and distance in such patients? Do you have any thoughts on that?
So yeah, I do, except I think Dr. Wright's formula is for high ACA ESO. I do not think he's talked about that for EXO. Ken Wright published a formula Actually, I remember it because I discussed it at the APOS meeting when he presented it, where for the high ACA ESO, he operated for, it varied in the over the years, but at least when I discussed it, for an average of the distance deviation with glasses and the near deviation without glasses. And in general, I am a firm believer in not operating for an accommodative component, the deviation. I base my, in ESO's, my surgery with full hyperopic correction. If he published anything about doing that for exos, I'm completely unaware of that. Are you sure he had a formula for intermittent exo with that?
No, some average of near and distance and
Yeah, the average of near and distance, to my understanding, is what he's advocated for accommodative esotropia. I just, so, but let's, for the sake of argument, let's say that he advocated that. So if you have an intermittent exo and they're 30 at distance and ortho at near, which is a common presentation, what you said would be operate for 15. I would say you're going to undercorrect every patient you operate on, because if anything, the problem with intermittent exo is it recurs, it comes back. Far more problem with long-term undercorrection than overcorrection. And if we're cutting my take and my data at least back this up, is you got to operate for the biggest deviation you find in intermittent exo. They're 30 at distance, but 40 when they look at a flagpole outside, or 40 after you've patched at distance after you patch them, operate for 40. So I'm looking for the biggest deviation. And I think if Ken Wright were here, he'd say the same thing.
Thank you.
Kushner, I just wanted to ask a question. When we're trying the over minus therapy in our cases, could we benefit additionally by decentering those glasses to get advantage of the prismatic effect?
Well, yes, you could. I find, of course, and I'm sure you know, that the amount of prism you get by decentration is a function of how strong the correction is. And typically, these are not very strong prescriptions. I mean, your young intermittent exos tend to be, low correct. I've over minus them a little. They're not the minus 10s, So I just have prism ground in, but grinding prism in is optically no different than if you can get the same thing, if it's a strong enough prescription and you can have them do it by decentration. To me, that's the same as putting prism in the glasses. But yes, it would certainly be acceptable.
Any other questions that you would like to ask? As we all know, it's a very complex topic and the incidence is rising.
I don't think the mic is, I'm not hearing you. I'm sorry, I'm not hearing is your mic muted?
And any other question anybody has to ask? Can you hear me now, sir?
Yes, perfectly.
I'm saying it's a very, very complex topic and there are many dimensions to intermittent exotropia, and it's one of the common motility disorders now, and most often we are operating upon intermittent exotropias, and the incidence is rising and myopia is also rising, and both these things are, I think, myopia is also adding on to the intermittent exotropias. And I think we'll need much longer discussion since we are running short of time. We'll thank Professor Kushner for a very, very insightful talk. And we look forward to further meetings with him on this platform. Thank you, sir. On behalf of the entire SPOSI, I thank you for sparing your time. Thank you, sir.
Thank you. And I just apologize profoundly for this thing with the video. I'm doing 2-3 Zooms a week and I've never had this happen. So I know how to work the system, and it tells me
next time we'll ensure, sir.
Okay.
Next time we'll ensure, sir, that there's no glitch, sir. And we are sorry for the
Okay.
glitch, sir. Thank you so much, sir.
I'm going to sign off. Thank you.
Please, sir. Thank you, sir.